Nerve palsies. Usually whenever you get a auscultation, you'll be asked what's the problem or what's the condition that this patient's suffering from, and it's either going to be a picture or video, or maybe you've got a history taking that you need to do. So what we're going to do in this video is break down the signs that you should be able to see within a video or a photograph so that you can tell what kind of nerve palsy the patient's faced with. We suggest that if you do have a binocular vision station, draw out the eye, draw out the muscles, and just remember what each muscle actually does. So when you actually go into the room and you start watching this video, you can see that this patient's clearly having some difficulties in horizontal gaze. My advice would be to first of all just watch the video without doing anything and pay complete attention to what movements are occurring. Then the second time you watch the video, So the second time that you watch this video, you want to circle which eye is the problematic eye. In this case, it appears to be this eye over here that is unable to move past that midline. So if we think about which muscles are where, we know that this is our medial rectus, in towards our nose is our superior oblique, up over here is our inferior oblique, superior rectus, inferior rectus. So this muscle here that's not working at the moment, that's our lateral rectus. If we remember LR6, SO4, everything else 3, then we know that the superior rectus not working, that's innervated by the 6th nerve, so we know it's a 6th nerve palsy. So when you give your answer, you need to remember that you have to state which eye is the one that's affected. So we know that it's the right eye that's affected. We know that it's also our lateral rectus that's affected because we're unable to move out past this midline. And we know that it's the 6th nerve that supplies the lateral rectus. So you would state that in primary position, we can see that there is a small ESO deviation. So there's a small esotropia in primary position, but the right eye in lateral gaze, so when the eye is looking out in towards right gaze, the lateral rectus is unable to pull the eye out, so we know it's a 6th nerve palsy. We now have a different scenario. So watch the video. So when we look across to right gaze and left gaze, there appears to be slight movements. We're looking up and down on our H formation, lifting the eye up so we can see what movement we have there. There looks like there is a slight upward deviation of the left eye at the moment. And now we're doing a cover test to see if there is any movements of our eyes. So remember, the first time that you watch the video, completely watch it fully, giving your full attention to the video itself. So there is a downward movement in this eye and upward movement of the right eye. When the patient turns their head, so they're looking in right gaze, there appears to be a much more obvious vertical deviation. So the left eye has to come down to pick up fixation. So this way, we're thinking most likely it's a 4th nerve. Let's just break it down. So when we look at the video for the second time, let's draw out our muscles. So we know that in this eye is where we have the problem. This is my medial rectus. That seems to be working absolutely fine. In this direction, it's my lateral rectus. Again, that is working absolutely fine. Going up and going down there, that seems to be normal as well. When we look up over here, that's shooting up a little bit. And when we go down, it's not going down quite as much as this eye is over here. So we know that there's possibly a problem here. Either this muscle is not working enough or this muscle is working too much. So we know that this is our inferior oblique and this is our superior oblique. So when we do our cover test just over here, we can see that the eye is now moving down slightly and this eye is moving up slightly, but it's only very slight. So usually when we turn our head so that we're looking in right gaze, this allows the eye to use these muscles more. If there is more of a vertical deviation when looking away from the affected eye, so this is our left eye, and this is our right eye. When we look away from the left eye, looking in right gaze, and if the vertical deviation is more, think more likely to be a superior oblique palsy. So when we give our answer with regards to what we think the problem is, again, remember to state the eye. So this is a left eye, superior oblique. So fourth nerve, remember LR6, SO4, everything else 3. And you would state that when we look horizontally, we don't notice too much of a problem. In primary position, when we did a cover test, there was a slight hyper deviation of the left eye. So the left is slightly higher up over the right eye. And it's worse specifically on right gaze. So a slight hyperdeviation of the left eye over right, which we can see in cover test in primary position. But when we specifically look over in right gaze, there is more of that vertical deviation that's present, because this is what you would normally expect with a superior oblique palsy. Now, just to differentiate between an isolated elevator muscle palsy in the other eye, you would do a head tilt test. This is another video, so we can see very obviously that the examiner is lifting up the left eye. So nothing seems to be done to the right, but the left eye is being lifted up. The eye seems to be having difficulty moving in all the different directions. So at the moment, although it's slightly down, it's not really moving down further. And it can't really lift up. It really can't go in any direction, even past the midline in towards the nose. So we're thinking most likely it's a third nerve. But what are the things that we really need to say? So let's watch it one more time. So first of all, we can see that it's this eye that's a problem because it's down and out in this position. It can't go past this midline and it can't go past vertically either. So where are our muscles? This is my medial rectus, elevator muscles, which is my inferior oblique and my superior rectus. But also the eye is slightly down and out. So why is it out? First of all, because the lateral rectus, which is supplied by the sixth nerve, is working, and it's also down because the superior oblique, which is supplied by the fourth nerve, is still working. So the muscles that are not working are all of these ones just over here, which is supplied by the third nerve. So this is most likely a third nerve palsy. So when we explain it to our examiner, you should be thinking, well, the eye is in a down and out position, which means that the muscles that are unopposed at this point is the lateral rectus and the superior oblique, which are responsible for a down and outward movement. The eye has a ptosis, which the examiner is lifting up so that it's out of the way, and the patient is unable to elevate past the horizontal midline, and they can't turn the eye inwards past the vertical midline either. So this is more likely to be a third nerve palsy. So when you have the different nerve palsy, what are the things that you really need to look out for? So in primary position, if you have a patient with a third nerve palsy, let's say that it's the right eye in all situations that is the problem. So let's say it's a right eye problem. Then in primary position, the left eye is going to be absolutely fine, right, nice and straight in the middle. But the right eye is going to be in this down and out position. You're most likely going to have a ptosis, and you could possibly have a blown pupil as well. So what you should be looking out for is this ptosis, the eye in a down and out position, and a blown pupil. If we had a fourth nerve palsy in the right eye, in primary position, what we would be looking out for is a slight vertical deviation. So it could be that the eye is slightly higher up, but we're not going to necessarily see that very obviously. The easiest way to check it would be to check in the opposite direction of gaze. So if it's the right eye that's the problem, if you look in left gaze, then what we would see is that this eye will be nice and straight, whereas this eye will be much higher up because the superior oblique coming and pulling the eye down is not going to work. And if we had a sixth nerve palsy in the right eye, in primary position, what we're going to be looking out for is a slight inward deviation or an esodiviation because the lateral rectus pulling the eye out is not going to be working. But in this case, actually, if we looked in right gaze, then that's where we'll actually find that the deviation is going to be worse. So if we look out across into the right gaze, this lateral rectus is supposed to pull the eye out, but it's not working. So the eye is going to be stuck looking pretty much straight ahead. So if you have a third nerve palsy in primary position, you should be able to figure it out. You'll see a ptosis. The eye is going to be down and out with a blown pupil. With a fourth nerve palsy, in primary position, the eye is going to be slightly higher up. But specifically, if you look on left gaze, you'll notice that there'll be more of a vertical deviation. And if you've got a sixth nerve palsy in primary position, you'll have a slight esodiviation, but more specifically in right gaze, the eye is going to be more likely to not be able to move out towards the right-hand side. So specifically, when we have a third nerve palsy, look in primary position. When we have a fourth nerve palsy, look in the opposite side of the eye affected. And when we have a sixth nerve palsy, look in the same side as the eye affected.